everyone, this is Alyssa, and in my video I am going to summarize how a patient with a neurological level of injury C6 ASIA B would present. A patient with an ASIA B has an incomplete spinal cord injury in which sensory function but not motor function is preserved below the neurological level. At the level of injury at C6, the patient would be expected to have full, intact strength in their deltoids, infraspinatus, teres minor, clavicular portion of the pectoralis major, and biceps brachii. They would have partial innervation of their serratus anterior and latissimus dorsi. In this video, I will be discussing how a patient with this NLI will transfer from a mat to a wheelchair with a slide board. In order for this patient to complete this functional task, they utilize compensatory movement strategies. Patients with this NLI may send signals to the muscles controlling the wrists, but not the fingers. The patient would use tension via tenodesis grasp to assist with picking up objects. With loss of triceps innervation, the patient has to utilize muscle substitution via closed chain mechanics to lock out their elbows. In order to do so, they would bear weight on their palms and use the anterior deltoid and clavicular portion of the pectoralis major to flex and adduct the shoulder. They maintain elbow extension by strongly contracting the anterior deltoids and external rotators. This patient also utilizes the head-hips relationship to move across the slide board. At this level of neurological injury, the predicted functional potential for an even height transfer ranges from some assistance to independence. One of the problems the patient had trouble with in the video was lack of trunk control during termination stability. The therapist had to provide assistance with stability, placement of their feet, and helping bring the patient fully back into their wheelchair. The second problem the patient had trouble with was weakness in the remaining innervated muscles in the upper extremity, which resulted in the decreased amplitude, speed, and smoothness in the transition. The patient needed therapist assistance to move safely across the slide board. In order to address the patient's lack of trunk control, one of the treatment goals could be, in 1 week, the patient will increase trunk control with use of bilateral upper extremities for balance during transitional activities to decrease reliance on the caregivers. The patient could start off by attempting to maintain balance with unsupported sitting. A progression to this exercise would be the addition of perturbations with support in back of the patient and a caregiver or therapist in front to protect the patient from falling. A regression of this exercise would be to weight shift in different directions with support from their bilateral upper extremities. In order to address this patient's weakness in the remaining innervated muscles in the upper extremity, a goal could be made that in 2 weeks, the patient will increase the strength in their adductors and medial rotators of the shoulder to be able to better propel themselves across the slide board. The patient can start off with pushing the trunk up from a surface in front of them while in their wheelchair. A progression would be to increase the range of motion or by practicing in the wheelchair with their hands on their thighs. A regression of this exercise would be to decrease the range of motion.